Much for those kind words. It's a pleasure to be here, and Dr. Murphy and I have known each other. I'm not going to say how long, I don't know. But it's a real pleasure to be here. I haven't seen so many people at 7 a.m. in the morning in a long time. Let me ask, is atherosclerosis a multifactorial disease or a unifactorial disease? Hello. Multiple out here. Multiple. Does anybody say unifactorial? Okay. I never saw so many colors. Well, if we go down these so-called atherosclerotic risk factors, let's see what happens. Family history, or the question is, how often is atherosclerosis a genetic problem? It's not our fault. We can blame our parents. Cigarette smoking, high blood pressure, diabetes mellitus, inflammation, dear God, inflammation, overweight, inactivity, stress, and something the matter with the cholesterol. Now, the Framingham people through the years, as I understand that operation, have stressed that the more of these risk factors we have, the greater the risk. And I have interpreted their studies as meaning that cigarette smoking, diabetes mellitus, high blood pressure, and cholesterol are roughly equivalent atherosclerotic risk factors. Everybody accept that? Really? Okay. Let's ask the question on each of these. Do you have to have this factor in order to have atherosclerosis? Do you have to have a family history? Does mother, daddy, or brother or sister have to have an atherosclerotic event for you to have one? No. Well, the genetic people who really worked on this, Brown and Goldstein and others, have come up with the frequency of a genetic variety of 1 in 500 people. Now, families eat the same food, and families tend to get the same diseases, in my opinion, but from a genetic standpoint, it's only 1 or 2 out of 500. When you see that 30-year-old ideal body weight person with a total cholesterol of 300, you're probably dealing with heterozygous familial hypercholesterolemia, if you rule out thyroid disease and a few other things. So, do you have to have the gene to have atherosclerosis? The answer is no. Do you have to be a cigarette smoker to have atherosclerosis? No. Do you have to have high blood pressure to have atherosclerosis? No. Do you have to have diabetes? No. Now, do you have to have an elevated C-reactive protein or IL-1 or IL-6 to have atherosclerosis? Is atherosclerosis an inflammatory disease? The lead article, New England Journal, 1986, atherosclerosis is an inflammatory disease. Everybody believe that? Does anybody believe that? Does nobody believe it? Well, I don't believe it. I think it's a myth propagated on the profession at the moment. Do you have to be overweight to have atherosclerosis? Does exercise prevent plaques? Well, if you go out and run 3 miles, like I understand your former governor, former president did, and then have 2 cheeseburgers at night before going to bed, it neutralizes it. So Does exercise prevent plaques? The answer is no. I think the best exercise are push-aways from the table. Now, what is stress? The stress causes atherosclerosis. What is stressful to one person is not particularly stressful to another. Stress, in my opinion, is impossible to get a handle on. Do you have to have something wrong with the cholesterol to have atherosclerosis? Hello, I hear yes and I hear no. Folks, we're talking about a disease that's going to kill half of us in this room. You just look at the person next to you, one of you is going to die from cardiovascular disease. So this is not an English class. Do you have to have something wrong with the cholesterol to have atherosclerosis? That's a very important question. The answer is yes or no. What is it? How many say yes? I see 3. How many say no?
No.
Well, I disagree with you. And if you take anything away from this talk, you can remember this fellow from Dallas, Texas, came into Little Rock and said, atherosclerosis is caused by something the matter with the cholesterol level, period. Now, I don't even put cholesterol as a risk factor. I put all these other things as risk factors. But cholesterol, in my view, is the cause of atherosclerosis. It's not inflammation. This is bunk stuff. This is the villain. Now, let's say you've got to go to the courts of the United States or wherever you want, and you've got to convince this jury of 12 over here that cholesterol is the cause of atherosclerosis. What arguments would you make to the jury? Or you can take cigarette smoking if you want to. You can take high blood pressure. You can take anything. But I wouldn't go to court with those arguments. I would go to court with cholesterol, and I think I would win. Well, in my view, there are 4 arguments that support the thesis that cholesterol causes atherosclerosis. Number 1, if you give cholesterol or if you give saturated fat to some herbivores, and they picked rabbits, these were the Russians, 101 years ago, and they produced plaques similar to those in human beings. Now, they didn't produce plaques in 1 out of 10 animals. They produced plaques in every single rabbit, and then they went to monkeys and so on. Atherosclerosis is one of the easiest diseases to produce experimentally. Now, you can take these same rats, put them in a cage, and blow cigarette smoke in their face their entire life. You cannot produce a plaque. You can raise their blood pressure to 200 over 110. You cannot produce a plaque. The only way you can produce a plaque is by giving cholesterol or by giving saturated fat. Now, nobody really knows why giving saturated fat raises the cholesterol level. Because the cholesterol formula, these benzene rings, and these fatty acid or saturated fat or unsaturated are these carbon chains with hydrogen atoms on them. So how can you give this chain of carbon atoms and raise a formula of cholesterol, which are these benzene rings? But that's the way it is. It's more important to know that it does than the mechanism of how it does it. Now, the second thing, so it's very important to realize that this is a disease that is easy to produce experimentally. You can't produce rheumatoid arthritis experimentally. You can't produce systemic lupus erythematosus experimentally. The easiest disease to produce experimentally is an endocrine deficiency. You take thyroid gland out, you've got hypothyroidism. The next easiest, in my opinion, is atherosclerosis. The second thing is cholesterol is in the plaques. The third thing, in my opinion, and these are from the epidemiologic studies. I think the best one is what was called the 7-country study, published in the 1960s. And what happened there is that Ansel Keys and his colleagues studied pockets of people in 7 different countries. In one country, Finland, the total cholesterol level of adults was about 300, 280. And in Japan, it was about 150. And they had a lot of countries in between. And what they found was that those populations with high cholesterol level versus those populations with low cholesterol level, these people had a very high frequency of atherosclerotic events. They had a very high frequency of dying from those events, and not shown in those studies, but the quantity of plaque. Some people call it the burden. The quantity of plaque in this group much higher than in this group. And the fourth thing, of course, is what? What's the fourth thing? Everybody knows. See, if I put it up here, you'd say, well, I knew that. What is it?
Just treatment.
Yeah, exactly. You take people with these higher cholesterol levels, and you lower those levels, and you turn those arrows around. So you decrease the atherosclerotic events, and you decrease the chance of dying. And some of this plaque is reversible. You can get it out of there. So in my view, atherosclerosis is not this multifactorial disease, something none of us can get a handle on. It's a unifactorial disease. It's caused by cholesterol. And if you smoke cigarettes, which is a dumb thing to do, if your blood pressure is elevated, or if you let your body weight come out to here, it makes it worse. Now, notice, atherosclerosis is a disease of herbivores. You cannot produce atherosclerosis in a dog or cat, a tiger, or a lion. Now, are you an herbivore?
No.
You're a carnivore. So you don't have to worry about atherosclerosis.
Omnivore.
Oh, you're an omnivore?
Mm-hmm.
Oh. Well, I don't know where omnivore fits, but you can decide yourself. Some characteristics of carnivores and some characteristics of herbivores. Now, do your teeth look like those of your dog?
No, sir.
They don't. What's the difference?
They're a lot sharper.
Yeah, you're sharp. They're very
Thank
sharp.
you.
Now, we have a few in the front of our mouth, but the majority of our teeth are relatively flat for grinding those fruits and vegetables we're supposed to be eating. Now, the intestinal tract of a carnivore is very short. It's about 3 times body length. You give a dog or cat something to eat, they got to go outside in a few minutes. Now, herbivores have very long intestinal tracts, about 12 times body length. So I'm 6 feet tall, so I presume my intestinal tract, I don't want anybody to look, is about 72 feet long. So if I were to eat that steak tonight, it would take about 4 or 5 days to roll through there. Plenty of time to stop up the appendix, develop diverticula on the side, hemorrhoids at the end, inguinal hernias, trying to get all this out of there. We're very different. Now, what about cooling our bodies? How does a carnivore cool their body? Yeah, they pant. And the reason they pant is that carnivores have no capacity to sweat. None. We can pant too, but we cool our bodies primarily by sweating or perspiring. Sorry. Now, drinking fluids. How does your dog drink fluids? They lap it, don't they? With their tongue. I know some human beings that do that too, but most of us try to sip our liquids. And vitamin C, the carnivores, they make their own. Of course, we obtain it entirely from our diet, And appendages, these carnivores have claws. I bet nobody in here has claws. We have hands or hooves. So folks, I think we're one of these carnivores, and we certainly conduct our lives as if we were, but I would suggest, as have many others, that basically this is our group. And if we have 21 meals a week, if we can knock that flesh eating down to 5 or 7, the cardiovascular health and cancer health, etc., would skyrocket. How are we going to reduce medical costs in this country? Our government is broke. So we've got to do our part, and we've got to move to the right. All of us, and we must set the example. Now, does everybody follow the guidelines regarding lipid-lowering drug therapy? That's a yes or no question. Everybody follow the guidelines?
No.
Ah, that's good. That's the answer I like anyway. I think the guidelines that were presented in 1988 put some sense into it. 93, losing a little sense. 2001, I don't think very helpful. And now, I believe the guidelines, I guess this is off-label, are a detriment to cardiovascular health. The guidelines, of course, are based on LDL and whether we have other risk factors and the goal. And the guidelines have to do with decreasing risk. They don't have anything to do really with preventing plaques. So if you don't have any other risk factors, or only one, like being a man over a certain age, the magical drug treatment number is LDL greater than 190. And the goal is less than 160. Now, I've never understood that. The average LDL, as I understand it, in people in coronary care units across the country with heart attacks is about 140. So this doesn't make sense to me. Now, if you have more than one risk factor, this drug treatment number falls to 160, and the goal is less than 130. And in the Jupiter trial, that trial was advertised as people with normal cholesterols. And they had to have less than 130 to get in the trial, and elevated HSC reactive protein. But I don't consider 129, 128 normal by any means. Now, if you have a heart attack, this number used to have to be 130, now it can be anything, and the goal is less than 100. And now we have the option, or it is reasonable, two different organizations, to be less than 70. Now, it seems to me, if it is useful to be less than 100 after a heart attack, surely it must be useful to be less than 100 before a heart attack. Now, I'm from Atlanta, so you maybe thinking there is a little different than in Washington, D.C., but my goal for everybody on planet Earth is an LDL at least less than 100, and if there's any possibility, little risk of blood pressure a little up, so on, I go for 70 right away. Now, in this country, we have something like 306 million people. As I understand it, about 180 million are over 20 years of age. At least 120 of those million have LDLs greater than 100. And 13 million people are being treated in this country, as I understand it, with a statin drug, plus or minus ezetimibe or niacin or something else. So it's a bottomless pit. If you have a heart attack in this nation, a year later, your chance of having an LDL less than 100 is about 60%. Your chance of having an LDL less than 70 is 20%. Have to make all A's essentially to get in medical school, and this is a neglected thing, in my view. Now, does everybody know the rule of 5 and the rule of 7 in statin therapy? I wrote an editorial on this in 1996, and I never meet anybody who knows the rule of 5 and the rule of 7 in statin therapy. So you can see the power of my pen. It's not very powerful. Well, I think it's important because I believe it's important to start the patient on the right drug and the right dose from the beginning. I don't believe in titration. I don't believe in the same drug for everybody. This person needs to be on lipid-lowering drug, Lipitor 10, reflex, habit. I think we can do better than that. Now, I have no stocks in any pharmaceutical companies. I have no stocks in any medical device company. I'm on the speaking committee of Merck, Schering-Plough, Merck, AstraZeneca. I used to be Pfizer. No more, Novartis. Okay, now what I'm going to show here are the 6 presently available statin drugs and their comparative doses. One is rosuvastatin or Crestor, 1.25 milligrams. Now, we don't have a 1.25 milligrams, but you'll see the rationale here. And then we have a atorvastatin, a Lipitor 5, so this is 4 times more powerful than that. And then we have simvastatin or Zocor 10, a lovastatin, Mevacor 20, pravastatin, Pravachol 20, and fluvastatin, Lescol 40. Lescol means less effective, but I sort of make fun of that. But just think if Lescol, fluvastatin had come out in 1970, it would have been an incredible drug. Now these doses lower total cholesterol on average of 22% and lower LDL on average of 27%. Now, let's look at 1970, what was available. In 1970, you could give cholestyramine, and that was 30,000 milligrams, and it lowered LDL 18%. Or you could go, that's cholesterol. Or you could go to cholestyramine, and we're down to 24,000 milligrams, and you get an 18% LDL reduction. And now we have ezetimibe or Zetia, and 10 milligrams lowers LDL 18%. Or if you have fluvastatin, 40 milligrams lowers it 27. So I call this incredible progress. Incredible progress. Okay, now the rule of 5 has to do with total cholesterol. The rule of 7 has to do with LDL. And what that means is when you double the doses, you get 5% additional reduction in total, 7% additional reduction in LDL. So you get the biggest power, you get the greatest lowering with the first dose. Okay, we double this dose, 2.5 of Crestor. They have that in Asia. 10 of atorvastatin, 20 of simvastatin, 40 lovastatin, 40, 80. And now we're at 27%, and this is 34%. So you can give any of these drugs to somebody with an LDL of 150 and bring it down to roughly 100. And then we go to 5 of Crestor, of the rosuvastatin, opening dose in this country, 20 here, 40, 80, 80, not FDA approved. Now it's 32% and 41%. The heart protection study of 20,000 people, which I consider the best of all the outcome studies, used simvastatin 40. Now that was a very high dose when that trial was started, and they got just over a 40% LDL reduction. And the side effects of that relatively high dose at that time was almost the same as placebo. Now we go to 10, 40, 80. These are not FDA approved. 37%, 48%. And then we go to 20, 80. These are not FDA approved. 42%, 55%. And 40 here, 47%, and about 60% here. Now, folks, this is really fantastic. That's incredible. These statin drugs are miracle drugs. When penicillin came out in 1943 in this country, everybody knew right away this was a miracle drug. The statins, in my view, are to atherosclerosis what penicillin was and is to infectious disease. And yet, the power of these drugs is not being utilized. It's not being utilized. Now, the average LDL in the U.S., as I understand it, in adults over 20 is about 130. So in my view, we need a 50% LDL reduction in this country, on average, to really make a big, huge dent in the frequency of atherosclerotic disease, be it in the coronary arteries, carotids, abdominal aortic aneurysm, peripheral arteries. It would be an enormous hit. Well, if you're going to use a statin drug alone, there are 23 doses there. You've got 3 doses that will give you over a 50% LDL reduction. 3 doses out of 23. And they're pretty high doses. Crestor 20, or Lipitor 80. Now, if you go to simvastatin, that's equivalent to 160 milligrams of simvastatin. Nobody uses that. 40 of Crestor is equivalent to 160 of atorvastatin and 320 of simvastatin. Nobody uses those doses. And the toxicity of the statin drugs, or the side effects, are related to dose. The lower the dose, the less the side effects, and that holds true of all the statin drugs. Now, everybody knows about Zetia, which is ezetimibe. Took me a year to learn how to spell it. But it's 10 milligrams, and I think it's a great drug myself. It's a small intestinal blocker of cholesterol absorption. Now, the statins work by decreasing production of cholesterol, primarily in the liver, and they make those LDL receptors more efficient. So LDL comes into the liver more efficiently and is excreted out the bile ducts into the intestinal tract. It recycles and gets out quicker. So these 2 drugs, in other words, work differently, and they work synergistically. Now, adding 10 milligrams to any of these statin drugs, you get an 18% additional LDL reduction. Additional. So the total LDL reduction by adding ezetimibe, Zetia, to the lowest dose of the statin drug, you get a 45% LDL reduction. Now that's fantastic. And the side effects of any of these statins at the lowest dose is the same as placebo. Same. If you add it to the second tier, you get an 18% LDL reduction, and now you're over 50%. So what's my favorite dose? Vytorin is Zetia 10, and Zocor 10, 20, 40, and 80. So Vytorin 10, 20, and this is what I take, you get over a 50% LDL reduction. Now that's what I like. I like these combination drugs. You get to be my age, systolic blood pressure is a little elevated. And for hypertension, these combination drugs, I think, are incredible. Novartis has just come out with 3-in-1, 3 drugs in 1 pill. You've got valsartan, amlodipine, and hydrochlorothiazide, relatively low doses. Boom! And it has a fantastic effect on systolic pressure and also diastolic. And I think we're getting that way in lipid lowering. There's going to be 1 pill, 1 copay, and more than 1 drug in that pill. Now, as you go higher, you get less effect of the Zetia. And the reason is because the statin, the higher the dose of the statin drugs, the less is produced in the body. So there's less in the intestine to block. So this becomes about 55%, and down here it's 12%, it's about 60%, and 10, as you go higher, it's about 66%, and 10 here is about 72%. So you can knock the dickens out of the cholesterol, LDL, with the statins, and even greater with the addition of ezetimibe. Now, I think of ezetimibe, and this is a very important phrase, as a statin-sparing drug. That's a key phrase, statin-sparing drug. Now, to get over a 50% LDL reduction, if you go from the baseline statin, you've got to raise the dose 3 times, 1, 2, 3, to get a relatively similar LDL reduction that you can get with the first dose by adding Zetia or ezetimibe to the equation. So my favorite of these 6 drugs is Vytorin, for the reason I mentioned, statin sparing. My next favorite is Crestor. I think Crestor is the most powerful of the statin drugs. And of course, you can add Zetia to any of these. The problem is if you add Zetia to Crestor, you've got to pay full price for both drugs. If you use the combination of Vytorin or simvastatin and Zetia, ezetimibe, you get one of them free, which not bad. Okay, let me summarize what I've tried to say. Number one, in my view, cholesterol is the cause of atherosclerosis. The cause. Number two, cholesterol is, and there are 4 arguments, in my view, to support the thesis that cholesterol causes plaques. Now, I talked about the guidelines for drug therapy. Now, the guidelines for drug therapy have to do only with decreasing risk. There's nothing in those guidelines that says, let's prevent plaques. Now, the guidelines for preventing plaques are quite different. Total cholesterol certainly has to be less than 150. LDL certainly has to be less than 70. And what does HDL have to be? What?
Greater than 40 for men, 50 for women.
Okay. Now, let's talk about people who have a total cholesterol of 130. And they have an LDL of 55. Then what does the HDL have to be? I'm not talking about people with total cholesterol 210 and LDL 130. I'm talking about people with total cholesterol low. You've seen people with total cholesterol 240 and their HDL's 45, and you get that 240 down to 150, and now the HDL's 25. Have you heard them? There's no evidence, in my view, yet that raising HDL prevents plaques. None. There's incredible evidence that lowering LDL prevents plaques. Incredible, and the lower the better. I say as long as HDL is greater than 20, when these are low, you're okay. Now, if it's 20 when the total cholesterol is 195, that's not good. Different scenario. So there's difference in guidelines to decrease risk and guidelines to prevent plaques. And these are the guidelines that I think we have to switch to in the United States. These keep people out of the hospital. And if we can just keep people out of the hospital, we'll save a lot of money. So the next thing I talked about, I think, was differences between carnivores and herbivores. And folks, whether we like it or not, we've got to move toward the H. Each one of us. You folks set the example. All these patients come in to see you, and they look at you. And what you say means everything, everything. So this is the way we've got to go. Think of it from the standpoint of the cow or the pig. In this country, we have, as mentioned, 300 plus million people. We have 100 million cows. Now, I don't know how many people we kill every day, but a good number. But we kill 100,000 cows every day. And we kill them differently. 100,000 every day. And we do it differently in this country than in Europe or Asia. When these cows get to be about 700 pounds, they're put in these feedlots. And there they're given 20, 25 pounds of grain and soybean, because we want to fatten them up. We want to marble them. We want to put that fat between those muscle fibers. And then they get up to about 1,100 pounds, and that's when we kill them. What happens is we kill them, and then they kill us. That's the way the system works. In addition to that, we kill about 300,000 pigs every day. And if you're a chicken, Churchill called the pig, our smartest mammal. And if you're a chicken, don't wander into the USA. We kill anywhere from 15 to 20 million chickens every day. Every day. And if you cook them, eat them, cook them well, because 60% have salmonella in them. And then the next thing I tried to talk about was the rule of 5 and the rule of 7. And I would post it on the wall here because I think it's important. And you can look at that chart and say, this patient needs a 52% LDL reduction. And this is what I need to do to get that patient there. And I don't believe in titration. I don't believe in starting low, and I'm going to remember to raise it later. I believe in starting at the right dose that does the job, that gets that LDL less than 70 or less than 100, or whatever you're going for from the beginning. And that's it, folks, and I appreciate the opportunity of being here. And Dr. Murphy, thank you for allowing this. And I guess I should apologize for not having PowerPoint. This is weak point. If there are any questions, I'll do my best. Yes, ma'am.
What happens if you can't tolerate any of the statin drugs? I get severe neuropathy even with the lowest doses of any of the statins. I'm on ZTF, but I can't tolerate any of them.
Yeah, well, you're unlucky. You're unlucky. Well, I don't know the answer to that. Some people decrease the dose to every other day. Some people every day, but a lower dose. We published a paper showing that fluvastatin in people had a lot of that problem. Switching to fluvastatin, the weakest of the statins, sometimes is useful. You just have to play it by ear. You know, it's like NSAIDs. You got to see which ones work. But it's very important. It's very important not to give up. Very important.
The only one that worked with me was Baycol, and they took it off the market. I could tolerate it.
Well, keep trying. Yes, ma'am.
What kind of words could you use to tell a patient or to convince someone who's been brought up on belief that 3 meals a day, you have to have meat with every meal? How do you convince them otherwise? Because it's near impossible.
Yeah.
I would think.
Well, that's why I like the drugs. Changing behavior for any of us is an extremely difficult thing. Now, I changed my eating habits. I grew up on hot dogs and hamburgers and all the rest. When I read about what we were doing to our cows and pigs and sheep and goats and chickens, I tell you, all you have to do is go into a slaughterhouse and see what happens. Read John Robbins. He wrote a book called A Diet for a New American. Read anything he's written. And boy, it'll change your habits. The turnover rate in the slaughterhouses in this country is 40% a year. Any of us can walk into a slaughterhouse and get a job just like that. Just like that. It's, I mean, even more important than that is what having a billion cows on the planet is doing to the planet. I mean, we can forget about our health. It's relatively unimportant compared to what we're doing for the planet, raising these cows. I mean, when we send grain to Russia like we did a few years ago, why'd we send it there? We sent it there not to feed people, to feed their cows, so they can eat steak and all the rest. The amount of acreage needed to grow crops to feed the cows is absolutely incredible. That's what most of our crops go to. They don't go to us, people. Yes?
I have 2 questions. One has to do with age limits. When would you start testing someone, and how young, when you start treating their cholesterol?
Oh, well, that's a very good question. Men get married now about 26. I think that's about average. And that's the time that a lot of men take out life insurance. Well, the best life insurance is a statin drug, with or without ezetimibe. You know, one of my boys is a cardiovascular surgeon, and I watched him operate. He's technically very good. I'm proud of him. But do you want to meet him sternotomy? We don't have to have a median sternotomy. We do for valve replacement, other things. we don't have to have atherosclerotic operations. But we can't start when we're 50 years of age. If we're going to do, men particularly, single men particularly, go to pot between 20 and 35. You just look at that waist going out. So there was a study in Circulation in kids. Average age was 9, and they had heterozygous familial hypercholesterolemia. And they tested hormones, thyroid hormones, growth hormones, and what these statins did to the kids, and they didn't do anything. So you can start these drugs safely at a pretty early age. But I think all of us, everybody know their cholesterol levels? Everybody know their blood pressure levels? I mean, I don't care how smart you are. It's stupid to have life insurance and have an elevated cholesterol level. It's stupid to have life insurance and not watch your blood pressure. The healthiest thing we can do is keep an ideal body weight, but that's the hardest thing. It's the hardest thing. Change people's behavior is god awful, but let me tell you, it's going to happen. It's going to happen. And we're not going to have people over to our houses 30 years from now and hang a pig up and feed everybody with a pig. We're not going to do that in 30 years. It's just like cigarette smoking. You know, I grew up, I didn't smoke, but everybody I knew did virtually. That's gone. Nobody smokes. I don't know anybody who smokes cigarettes anymore. A pack of cigarettes in New York City costs $10 now. I think that's the way to go. I believe in taxing cigarettes to the hilt. I believe in taxing Coca-Cola and Pepsis to the hilt. Things that are bad for us, tax them. And every time the taxes on cigarettes go up, the percentage of smokers go down. Yes?
Well, the other question is obviously on the other end, and this is one that I encounter a lot. I'm sure the other doctors do also. All right, we have a woman, postmenopausal woman, and her workup, we eventually comes to coronary angiography, and we find that she has little or no disease. Let's say no detectable coronary disease by angiography, and yet she's got a high LDL. She also probably has a high HDL as well, but she has a high LDL. These folks should be treated even if they're 65 years old and have no coronaries.
Absolutely.
Okay. And then the same thing for let's say a 75-year-old woman who's non-invasive workup that says she has no ischemia, 75 or 80, and she's got a high LDL, never been treated before. I'm just trying to think, is there a point in time in which the evidence for no ischemia or at least no coronary disease would indicate they'll probably die of something else?
The average age of death in this country in 1900, I believe, was 50. The average age of death in this country through 10 is 80, approximately, almost, certainly in women. In Okinawa, the average age of death is about 95. Now, they have the best records in the world of birth dates, other dates. It's believed that a pocket of population in Caucasus, Russia, Georgia now, the place in Ecuador, group of people, in rural Africa, before it's getting so urbanized. These pockets of population, these people have very low cholesterol. They're at ideal body weight, their blood pressure is down. They live 90, 95, 100 years, and their last 20 years is not chronic disease. There were a group of physicians in Africa that studied rural Africans in the 40s, 50s, 60s, and what they found, native Africans, they didn't have atherosclerosis, they didn't have high blood pressure, a Burkitt tumor fame. he went there as a general surgeon, and he said, you know, what's going on here? I don't see any appendicitis. I don't see any cholecystitis. I don't see any gallstones, kidney stones, hemorrhoids, cancer of the breast, cancer of the colon, cancer of the prostate gland. These are very rare in these populations with very low cholesterol levels. Now, the first person thought this was due to sugar in the Western societies, because these are all the diseases we get in the Western world. Burkitt thought it was fiber, and so these people had very quick transit times. You take in food, boom, it's out in 18 hours. In this country, eating all this cows and pigs and so on, our transit time's 50 hours. Plenty of time for that stuff to lay in there and cause diverticulitis, stop up the appendix, produce hemorrhoids at the end, inguinal hernias trying to get it out of there. And then it switched to fat. But we have diseases in this country where we're spending all our money, and most are preventable. Most are preventable.
Dr. Roberts, how do you explain the negative backlash against Zetia from the Jupiter trial? It seems to be pretty overwhelming in the press, but not really borne out by much scientific fact.
The enhanced study, yeah, I think it was a god-awful study. Unfortunately, but the press gets hold of these studies, and it can be a disaster. Now, they studied 720 people. I believe that was the number. All of these people had LDLs greater than 300. I mean, how many do you see a single patient with an LDL greater than 300? They had 720. And they were divided into two groups. One group was treated with simvastatin 80 plus ezetimibe 10. The other group was treated with simvastatin 80. So the only difference was ezetimibe 10. And this group had a drop from LDL from 319 to 141. This group had a drop of LDL 118 to 191. That's a 17% difference. But these levels are still pretty high. Now, this was an animal medial thickness trial. It went on 2 years, and the mean age of these people were 48. Now, the animal medial carotid thickness at the beginning was 0.71 millimeters, which is essentially normal. And there was no significant difference between this group and this group in progression of animal medial thickness, much less regression. And the outcomes in these 2 years were non-significantly different. Okay, so how did the press interpret? How did the committee, the expert committee of the American College of Cardiology, interpret this study? Well, it shows that you don't have to use a drug, combination drug, which, costs $110 a month, versus one that costs $4 to $6 a month. Because there was no difference in any of the various endpoints. Well, in my view, this was a terrible design. If you're going to do a study, you've got to have a significant difference between the treatment group and the control group. The only difference here was ezetimibe. I suspect that they would show a difference here in 4 years, 3 years maybe, 5 years. Now there were 2 other trials. Now pharmaceutical companies, rightfully so, like these surrogate measurements, intimal medial thickness, intravascular ultrasonic imaging, because you can have less than 1,000 patients. If you do an outcome study, you got to have 5,000 patients. Costs money. Who pays it? Patients pay it. At any rate, Pfizer did a study on roughly the same population, and they used Lipitor 80 versus simvastatin 20. Now, Lipitor is 2 times more powerful than simvastatin. So if you use a 4 times difference there, you've got an 8 times difference between the treatment group and the control group. You didn't have that here. AstraZeneca has been very clever. They did the same study with rosuvastatin, Crestor 40 versus placebo. And by golly, they showed a difference. Can you believe that? So you've got to have a difference. Now, I think Sherry Plow here said, well, look, if we make this dose and that dose the same, and the only difference is Zeti at 10, we can show right away that, by golly, that's a miracle drug addition. Well, you've got to have more than a 17% difference in an endpoint if it's only 2 years. Now, what happens? So, Sherry Plow Merck said, okay, FDA, we'll do an outcome study. 19,000 patients. 19,000 patients. 4 or 5 years. And it's the same setup, but it's an outcome study. So it's very expensive, a lot more patients. Who's paying for it? Patients are paying for it. But I think this was a terribly designed study. And then it was followed by the SEAS study, which were patients with aortic valve stenosis, our second most common potentially fatal heart disease. The average mean age was 68, and these patients were treated with simvastatin 80, I believe, one group, and the other group simvastatin 80 plus ezetimibe 10. Maybe it was 40, or maybe it was 40 simvastatin. I forgot exactly. But what it showed is no difference in the time period. Well, you know, when you're 68 years old, you got aortic stenosis, you got rocks in there. You got rocks in that aortic valve, and that's why surgery is so successful. I don't believe, incidentally, in this percutaneous aortic valve implantation without replacement. I don't think that is going to fly. In Europe, it's just going berserk. 8,000 patients have had that procedure. Not me. But I think the wrong message came out of this study. If these patients were started with a bicuspid valve when they were 20, they may not have had all these rocks at 68. So you can have a wrong message. Then what happened here is the cancer was slightly increased in the treatment group compared to this group. Zetia produces cancer. Well, then the finest statistician in UK went over all the 19,000 patients that had been in their study for a year or two and some other studies, and showed no difference in cancer frequency. The FDA came out with a fact sheet or whatever you call it a month or two ago, and said there's no cancer scare with Zetia. Our analysis of all the data shows no increased cancer. Well, you know, this has been in the press. So you can't retract things from press. I mean, when we publish a manuscript that later proves to be fraudulent, you put a little retraction in. Nobody reads those retractions. You know, the damage is done. And these are very unfortunate, but I suggest that, you know, you don't put all your marbles in one study. Now look at a lot of studies together. Crestor, when it first came out, there was this guy, Steve Wolf, may have been paid by some competitors, pharmacy companies. That's the rumor. He was trying to wipe out Crestor. And so for a couple of years, Crestor, you know, had a terrible problem. So these things happen, but it's unfortunate, very unfortunate, because these are fantastic drugs and they must be used. And in my view, for the reasons I've given, I think the movement is going to be to more and more combination drugs, because you can be on lower doses and get fantastic effects. That's all I know, and I appreciate it very much. Yo, here.
I had a quick response to Paula. I just want to put a plug in. There's a new documentary that came out called Food Incorporated. You don't have to go through the pain of reading the book. It's 90 minutes, and it will motivate you to eat less meat and rethink about where you get your meat from. And I had another question for you, Dr. Roberts. In regard to low-fat dairy, and given how ubiquitous that is in today's society, have there ever been any studies done, or what are your thoughts as to the means by which that dairy is made low-fat, by taking the fat out, and then powdered milk is usually added to add body to it, and that powdered milk is oxidized? Have there ever been any looking into any of that sort of thing?
Well, you know more than I do. I think that don't drink any milk other than skim milk. You know, if you drink 2% milk is 33% calories from fat. 2% milk is not good milk. Whole milk is 4% calories from fat, and it's 50% calories from fat. The only good milk is skim milk. You know something I don't know, but don't drink whole milk. Don't drink 2% milk. Don't add salt to your food at the table. Now, I used to sit down and pour salt on my food before I even had a single bite of it. That's nuts. I quit that. My blood pressure started going up. I said, Robert, you idiot, quit it. And so I did. It took about a month to get used to it. And then you don't want it. So we can all improve our health. Thank you.